Thank you for your patience. Last week, we canceled the meeting because we had appropriations subcommittee meetings, and fortunately, we usually meet on Thursday and Friday, so the decision was made to meet all day. Rest of the evening on Thursday, cancel the meeting. I think we got finished about 6 o'clock that night, but we've never done it that way before because we didn't have to come in on Friday to work on the budget, even though some of us came in on Friday, but it was not budget day. So it was a little bit different, and I wasn't anticipating that. So with that, I'd like to ask Senator Kirk if you could have an invocation for us. I would appreciate it.
Sure. Let's pray together. Father, we just come now in Christ's name, and we know that you're called by many names in the Old Testament, and one of them is Jehovah Rapha, the God that heals. So we just pray, Lord, for the decisions that are made here in this Health and Human Services Committee, Lord, for the healing of people in Georgia. And so give us wisdom and guidance as we discuss these bills. In Christ's name, amen.
Thank you. Amen. So I know that today some people have some other meetings. It's kind of tenuous about whether you can be here and not be here. Our goal is to, we have to vacate this room at a certain time also, so we're going to kind of see how things go and who has to go. I know the DOT has board elections today. Does anyone have to participate in those? And mine's at 3. Yours at 2? Senator Counselor, you don't have it?
3 o'clock.
3 o'clock, yeah. Okay, so we'll see how it goes and see how many people, if we can maintain our quorum. Let the record reflect we do have a quorum today. It's Tuesday, February 13th, and we are starting a little bit late, past 1:30, and I appreciate everyone's indulgence. If you would like to sign up to speak for or against any of these bills, the sheets to sign up are... There's one sheet up there, but I have some sheets. If you've already signed up, you're good to go. So with that, there's several bills. We just went over the bills a few minutes ago. I think there's 45 bills in the Health Committee. So we anticipate these bills to start moving right along. That we're not going to do House bills until after crossover, but there are several Senate bills, and we will start working on these other bills. So with that, I'd like to bring forward Senate Bill 351, and this is the Advanced Practice Nursing Bill. And we do have a substitute. So we are working on we're working on LC 372586S as a substitute to Senate Bill 351. One of the things that I had heard about the bill was a particular thing that struck home with me that I also agreed with, and that was the amount of hours in clinical work that a person has to do before they start practicing as a nurse practitioner or a subspecialty. So that's why I wrote a substitute bill and included some of those things. I think the physicians had turned it in, and I included some of their considerations into the substitute. So with that, let me just start out and say thank you to all the committee members who have worked on the rule. Health care, I think I counted up 5 different, I'm not sure, don't let the newspapers quote me, but 5 pieces of legislation on the rural task force issue and traveling the state. And in the interim, one of the things that repeatedly kept coming up was workforce development and the lack of health care professionals. And I do want to tell you, I have another bill that I'm going to drop if anyone is interested in it about the physician workforce and kind of changing that around. So that bill will be coming forward. But this bill expands the scope of practice for nursing. And it's not an issue that hasn't been around. It has been around for a very long time. but no one has brought the issue forward in the last couple of years. But when we were traveling the state, and I do meet with a group of Nursing Coalition, and they are the deans of all the different schools. And it's public and private. It's Emory, Mercer, Augusta, Brenau, the list goes on of all the nursing schools and even the technical schools. But they do have a nursing coalition. And one of the issues that got brought up repeatedly to me is that we're educating these young people and some people who go into nursing as a second profession. We're educating them, but we're not allowing them to work at the fullest extent of what they're taught in school. And that is because Georgia has some of the strongest scope of practice laws on nursing in the United States. And when I go to all these rural areas, and I have to say how much I enjoy y'all's areas, it just, kind of clicks in your head like, oh my gosh, you got these people out there, you're churning them out of school, but they can't go out into these areas. They're ready, willing, and able to go to work, but they are not allowed to go and work at the fullest extent. So you say, well, they could go and work if they were attached to a physician in a contractual basis. And unfortunately, there's not enough physicians, or the physicians don't want to have that kind of agreement to be able to do that. So that's one of the reasons that I worked on the bill, is looking at the rural areas. And I understand it's very controversial. There's nothing in this health care committee that we do that is more controversial than scope of practice. And one of the reasons now the scope of practice issues seem to be exacerbated is because of the changing infrastructure of health care, not just in Georgia, but obviously in the United States. And when you see the Medicare and the Medicaid cutbacks, the things that are occurring in Washington, the dollar gets squeezed. And when the dollar gets squeezed, it gets squeezed on the providers too, whether those providers are hospitals, nursing homes, or individual practitioners. The dollar gets squeezed. So it even further complicates the scope of practice issues. And I realize it's not comfortable to do these issues. I've had many war battles up here over scope of practice, to say the least, and they're my least favorite thing because, it's like one big family, and you got one big family fighting with one another. Everyone is working for the best interest of the patient until, unfortunately, it comes down to the dollar sign. And that's just my personal opinion. But that seems to be the issue with scope of practice. It's everyone protecting their own turf. And it's very good to get up here and talk about collaboration. But when the bottom line meets the bottom line, it's all about the dollar bill. So with that, I want to say that the summary that I came up with on this particular bill was to talk about registered nurses having the ability to practice at that extent they're taught in the university settings in the rural counties. And everyone asked me, well, why don't you just do a full scope of practice for the whole 10 million state of Georgia? And I said, well, it's kind of like the doctors. Everybody flocks to where you can make money. And where you can make money is usually in those suburban areas where you have a revenue source and a stream of money. And if you look at where primary care practices are, I know I belong, and y'all met Dr. Hughes that came here at the beginning of session. Those big practices are located in the northern suburbs outside of 285. And that was one of my main concerns. If I open up or try to open up scope of practice for nurses, they're going to go to the same places that the physicians go. They're going to go to Johns Creek, Alpharetta, Dunwoody, Buford, all these great places, but then you're left when I go to Hayhira and down in your neck of the woods, there's nobody to practice. And I did not want to compound the problem with a full scope of practice for the full state. I want to kind of dangle the carrot and entice these people. Yeah, you want to work to the fullest extent of what you're taught. Well, you got to kind of put your feet where your talk is and go to those areas where you have that ability to practice that full scope of practice. So with that, I chose to do it for the rural areas, and I actually copied Senator Burke's bill about what was the definition of a rural area. And that's the exact same language that we used in the rural tax credit bill, and that's where that came from. So it's a population of 50,000 or less. So one of the issues that came up with is, where does the practitioner live and work? And, you know, when I first thought about it, I said, well, they have to live and work in the area. But then I got to thinking about areas like Augusta, Georgia, and I'm sure some of these people that are here can explain this much better than I can. So if you have someone working in Augusta, but they see the need, I think it's Turner County and some Centerstone, some of his very poor areas, and they would like to go out there. So the way I envision it, and they've actually got some handouts about this, where the practitioner works is considered like the mothership. And if they're in Augusta, which would not fit that 50,000 or less component, and when they're there, but yet they go out to Turner County. When they're in Turner County, they would have a full scope of practice. But if they were in Augusta, they would not. They would be in a contractual agreement. So one of the questions got brought up, well, what if they're seeing people in Turner County, and I'm not sure that's the exact county. Is that the right county? What's the county outside of Augusta? Burke County, there you go. Yeah. I'm sorry. Jenkins, yeah. When you go out there, I know I work with Senator Stone all the time, and he tells me, I haven't actually been there, but that's one of the areas I hadn't been in. But if you're out there and the patient comes to Augusta, then they would be treated with a restrictive scope of practice. But if the actual provider goes to Turner County, then they would have the full scope of practice. Burke County, if a prescription gets called in, it got called in when they were in Augusta, then it would be restricted. But if the provider is out there in Burke County, then it would not be. So that was the rationale, and I think there's some handouts about that. One of the other issues that came up in the bill was, what are you allowing them to do? And I did change the language from the original bill that was submitted. I think it said x-rays or no, it didn't. It said CT scans, and I changed that to radiographic image testing. They would be able to order those.
What does that mean?
That would mean they could order a CT scan or an MRI or a chest X-ray, a mammogram, yeah. So then the other thing was the ability to prescribe furnish pharmacological agents and controlled substances. I realize that is a very touchy subject since we've worked so diligently on the opioids, and I would expect these providers to participate with the PDMP. And the doctors say, well, you're kind of adding to the compounding the problem of more people providing controlled substances. And I would have to say that we're actually putting money in the budget to augment the current PDMP, because only 82% of physicians, even though the deadline was January 1st, only 82% have met that deadline. So they would fall into the same category as registering on that PDMP, and hopefully they'd do a better job than the physicians do. So with that, these independent practitioners would not be subject to the protocol agreement requirements right now. The way I understand it, and they're going to come up and talk about it, if you do have a protocol agreement, it is a contractual agreement. The actual APRN has to pay the supervising physician a certain amount of money, and I'm sure they can give you what those are typically. I really don't know what they are. The one thing I did add in this substitute that It holds a degree from a graduate nursing program that meets the standards set by the National Accrediting Agency and the National Certifying Board. The program must include a supervised direct patient care clinical component. I know the House Chairman is very interested in these online schools, and I'm very interested in them too because I don't like them very much, and I have to say physicians have online schools too. So I put in here a component, APRN graduates with fewer than 12 months and 24 hours of licensed active practice in an initial role in population focus, or fewer than 12 months and 1,200 hours for any additional role in population focus, must have a formal agreement with a collaborating provider. And that provider can be a physician, osteopathic physician, or a PRN with 5 years experience and licensed in Georgia. An APRN practicing with a collaborative partner may not engage in solo practice except for a role in population focus in which the APRN has met the registration or the requirements of this bill. And the APRN who satisfies the requirements to engage in solo practice must notify the board that these requirements have been met. And as y'all know, we do have another bill coming forward about the removal of nursing, the 164,000 nurses in the state of Georgia out from underneath the Secretary of State and give them the same prerogatives and parameters that dentists, pharmacists, and doctors have by forming their own board, and that bill will be coming forward this coming Thursday. So with that, I know it's complicated. I've worked very, very hard on it. I know y'all appreciate, and I've talked to a lot of you about the journey that I've been on and all the different things that I've come up with. A lot of people aren't happy with it. A lot of people are happy with it. A lot of people don't know. So I'm going to go ahead and let those come forward. Yes. Yes, sir.
Can we ask some questions before people testify so they may be able to answer the questions when they testify?
Sure.
Okay, I just have a couple.
Sure.
Primarily, I want to make sure I understand, and I apologize, I'm working off the substitute, not the original bill, but the changes in the radiographic, I think before it was CT scans, as you said, now it's chest x-rays, CT scans, and MRIs, right? Okay. I understand that.
Well, there's many x-rays that you can order.
No, I understand.
Yeah.
Okay.
But it's a full, you can order.
All right. The part of the bill that bothers me a little bit, and I want to be clear on it, is the controlled substances. And the reason we've spent all this emphasis here on the opioid problem and overprescribing of drugs
Right.
and so on and so forth,
Right.
and now we're going to go out and expand that and let more people do it. And I don't, this is me, Fran, not,
Right.
I don't think we're being very consistent.
Right.
And I've talked, in the last day, I've talked to both sides and suggested to both of them that I think it makes a lot of sense for them to get together and try to work out a compromise, particularly in that area, because I think that's a real problem for some of us. The other part that you've added in the bill, I read about that on the, see, people don't think we read this stuff, on what they gave me today about the legislative compromise, and that's what the part is where you're letting people do the training for the ones, the new people.
Right.
And that's where, that basically, that legislative compromise, that's your lines 43 to 54 or whatever it is in that area. So,
Yes.
but the big thing for me, and I don't think I'm the only one, and that was before the radiographic imaging, is the controlled substances. I just, I've got a problem with that, and, you know, I'd like to see, and I want to hear some testimony, but I'd like to see that these two groups try to sit down and work something out there based upon the direction we're taking on everything else in the state.
Right,
So that's
right.
end of my comments.
Yeah, and I don't disagree with you on the opioid, and I understand what you're talking about. And, you know, I considered about taking that out until I heard about the almost 20% of physicians that aren't even registered. They're not even in compliance with the current law. They testified in our appropriations hearing, the lady that runs the PDMP, about how many physicians are registered. and almost 20% haven't even bothered to register, even though we're in the midst of an opioid. And I understand about the providers, and I'm willing to take that out. I'm willing to compromise on that.
But I think it would be very helpful if these groups actually sat down with each other and tried to work this thing
Well,
out.
they have, and the nurses have been here every single day since the session began, and there's actually a picture of them in the Valdosta Times on the front page with them saying how much they love physicians. And, you know, that's what's remarkable to me. You know, a primary care physician, I go to a primary care physician, they're gatekeepers. And that's essentially what these nurses are. They're gatekeepers. If you've got a cardiology problem, they hear a heart murmur, you got, you know, blockages, you're short of breath, then you go to a cardiologist. If you got urinary tract problems, you go to a urologist. You got your prostate, you go to the urologist. You got this, you go somewhere else. They're basically gatekeepers. And that's what the insurance companies are mandating, that, you know, yeah, they can take care of the diabetes or some problems, the hypertension, but they're basically gatekeepers.
But you are comfortable taking out the controlled substances?
Yes, I am.
Okay, thank you.
And that's because, like you said, we've done so much work on that. So with that, I know time is of the essence. Let's go ahead and get started. We'll start out with the opposition. And I have been talking to some of the physicians, and I have taken that into consideration, some of the issues you had about the online schools. You know, I got the same problem with the online medical schools in the Caribbean that were around when I was a dinosaur, and people went down to the Caribbean, you pay enough money, you come back with a sheet of paper that says you got a degree. So with that, Dr. Leguani Beck, I'm not sure if I said your name right. Oh, God, you don't, okay. You can tell that's doctor writing, huh?
That was me.
Oh, okay. Georgia Academy of Family Physicians, and they're opposed.
Yeah.
You know, what's remarkable to me, and I talked to the family, I talked to the Pediatricians Association. You know, I've been elected 30 years. 30 years is a long time. 30 years is probably longer than some people sitting in the room. And what's amazing, I've been in healthcare that whole time, and most of y'all already know this. And I've worked with all of these providers for all that time. And what's amazing to me is I can't get the consideration of, you know, that have been around that long, that I've worked on these issues, and I expressed that to some of the opponents on this, who have actually given me awards before, like the group that's standing before you.
Good afternoon.
Thank you very much.
Good afternoon, senators and distinguished committee members. And actually, before I get started, Madam Chairwoman, I think I would take a little bit of a different stance on your opinion or your view of family physicians. We are much more than gatekeepers, actually. We manage 85 to 90% of medical problems that walk through our door.
Let me just take exception. I was talking about my physician.
Okay.
Whenever I go in with a heart leg, I go to the orthopedist. You got this, you go there. I was just talking about
Okay.
my personal experience.
Well, you're welcome to come to our practice at Emory. We can manage everything you have practically. Okay. Yeah. First, I'd like to thank you for your interest in the health care of rural Georgians and for devoting so much of your time and attention to this important issue. I think we all can agree that access to health care is a critical issue facing our state, which ranks 41 out of 50 in primary care access and last in maternal mortality in the United States. And from what I've recently learned, third highest in infant mortality. I appreciate this opportunity to speak with you all today regarding the proposed Senate Bill 351, a bill that essentially expands the scope of practice of nurse practitioners without patient safety controls or medical oversight on primary medical care in 74%, 118 out of 159 counties in the state of Georgia. My name is Teresa Beck. I'm a board-certified family medicine physician, fellow of the Academy of Family Physicians, former program director for the Emory Family Medicine Residency Program, and current assistant professor and clinical faculty in the Department of Family and Preventive Medicine at Emory University School of Medicine. I've had the privilege of practicing in Georgia since 1999. All of that time has been spent here in Atlanta with Emory, training hundreds of residents and medical students and caring for thousands of patients, both in the clinic and hospital setting, most of whom are uninsured or rely on Medicaid or Medicare for health care coverage. I am here today on behalf of the Georgia Academy of Family Physicians to voice our strong opposition to this bill as currently written. We are an organization representing over 2,900 family physicians and our patients here in Georgia. There are several reasons we oppose this bill, and you've actually mentioned some of them already. First and foremost is our concern for patient safety. Some who support this legislation might argue that some care or poor care is better than no care at all. However, health outcomes data show that medical errors are now the third leading cause of death in this country. When patients seek care, they deserve competent care that doesn't lead them into further health problems, but rather leads them toward the wellness they deserve. All fully trained physicians are required to complete a 4-year bachelor's degree, 4 years of medical education, and then a minimum of 3 years of residency that include 12,000 to 16,000 hours of clinical patient care. Family physicians are also required to complete 150 hours of continuing medical education training every 3 years. If board certified, must sit for their board exam every 7 to 10 years, along with completing annual requirements to maintain their certification. Physician education is standardized by state medical boards. Each physician is required by law to carry his or her own medical liability insurance. There is a reason for this degree of education and clinical training. Health challenges can be complex to diagnose and to treat, especially when medications are involved in caring for patients. By contrast, advanced practice nurse practitioners are only required to complete a 4-year bachelor's degree, 1.5 to 3 years of master's level coursework, and complete between 500 and 1,500 clinical hours before becoming fully licensed to practice. That is less than 10% that required for medical doctors. They are not required to complete mandatory standardized continuing medical education that is needed to bring modern care protocols to everyday clinical practice. APRNs are also not required to sit for nursing board certification at standardized intervals or carry medical liability insurance. Secondly, we believe that this bill does nothing to alleviate the major concern here in Georgia and throughout the country, the shortage of health care access for rural and underserved areas. According to the Georgia Physician Board for Physician Workforce, there are only 9 counties without a physician and only 15 counties without a family physician. That is less than 10%. Research shows that in states that have an APRN independent practice, that APRNs actually do not move to rural and underserved communities, but continue practicing and serving in urban areas. Finally, this bill has the potential to add to the existing problem of overutilization of scarce healthcare resources and increasing costs due to inappropriate referrals and ordering of imaging, such as CAT scans, that may not be medically indicated. However, what is most concerning is the potential for overprescribing of medications such as antibiotics and controlled substances that could worsen the opioid crisis in our state. Georgia ranks among the top 11 states with the most prescription opioid overdose deaths. In a state that is battling an epidemic of opioid and substance abuse and addiction, we strongly feel that it is unwise to allow an additional group of clinicians with arguably far less training to be able to prescribe controlled substances and without appropriate supervision or guidance. We fear that this may exacerbate the opioid crisis in our state, which we know affects rural communities in disproportionately greater numbers. The Georgia Academy of Family Physicians is the only medical society devoted solely to primary care. Nearly 1 in 4 of all office visits are made to general and family physicians. Today, family physicians provide the majority of care for America's underserved and rural populations. The GAFP recognizes that nurse practitioners are an integral and valuable part of the physician-led team. However, this concept, as presented in this bill, will not alleviate the problem our state has with access to care in rural and underserved communities, and in fact, may add to the current crisis that our state and indeed our nation is facing in fighting this opioid epidemic. The GAFP believes that health professionals should work collaboratively as clinically integrated teams in the best interest of patients. We believe that a safer and more viable long-term solution to the solution of to the shortage of health care in rural and underserved areas of Georgia lies with the use of technology and the expansion of high-speed broadband to rural residences and community health facilities with telehealth services reimbursed by insurance providers. That is the best policy for providing all Georgians with access to competent, safe, and affordable primary and specialty care. Thank you, and I'm happy
Is
to
there
answer
any
questions.
questions? I think we've got 3 people. I got a couple of questions first. Do you know what percentage of the family physicians are registered with the PDMP?
No, ma'am, I do not. I know that 100% of our practices,
You're in Emory.
Emory Family
Do you
Medicine,
know what percentage of your group works in rural Georgia?
As I mentioned, I work at Emory, and we are in Atlanta only. So none of the physicians
I-
in my particular
No, I'm
group.
talking about, I thought you represented the,
Oh, the GFP.
yeah.
Faye, I'm not sure if you know that number off the top of your head.
I want to say it's 68%, but I can circle back.
68% work in the rural area?
In fact, yeah, in the rural areas, it's family physicians by far than any other clinical group, nurses, any type of specialty that are in rural areas.
So your answer to the rural crisis is broadband and telehealth?
My answer to the crisis is
Other
using
than more
technology.
providers?
Actually, it's more than that, quite honestly. I think medical education should, including nursing schools, medical schools, should be required to recruit and accept a certain percentage of students from rural areas.
Like Mercer? Okay. Senator Miller?
Doctor, she raised a good point, and I believe right now, the nurses, by and large, their malpractice insurance would be under who the doctor's, probably the doctor's insurance. Is that a correct statement or not? You have your, you ca- you all-
Okay,
that's right.
they're going to come up, and don't answer questions, but, well, they're going to come up and you can
Well,
ask
but
questions.
that brings me another question. Is somewhere in this bill, if they're gonna be practicing independently, we need to require that they have insurance, and that's not in the bill.
Okay.
So that, the insurance issue, I think, is, I just was curious if they had it, then they, obviously
Yeah,
they do based on
and
what
I
they
think
said.
they can-
But I think you have to if you're gonna do the independent practice, you've got to have an insurance provision in this bill as well, just like. we
Is it
did-
in the physicians?
Yeah,
It is?
okay. that's
Yeah,
all.
okay.
Thank
Thank you. Appreciate
Thank
it.
you.
So next is Dr. Carmen Rivali. Can you ask the next one? I think they're the same. I'm not sure, but if they're not, we'll get her back. I didn't see your light. Did you have your light on?
Pardon?
I'm sorry.
Hi, Chairman and members of the committee. This is not my natural voice.
You don't have the flu,
But bear
do ya?
with me. It's not the flu, it's the crud. I'm
We're
Carmen
familiar with
Cavalli, a physician in Georgia, and I'm speaking on behalf of the Medical Association of Georgia. I provided handouts to you that I believe you might have, which includes sources for some of the comments that I'll be making.
What were yours? Do you
Derek,
have them?
Yes, you have them.
Sally, normally have a 24-hour rule, so if I don't have them this year, and before the meeting starts.
We'll hand them out afterwards. Go ahead.
Okay, thank you. But they do have sources for some of the comments I'm making. Thank you for allowing me this opportunity to speak regarding Senate Bill 351. This bill has the admirable goal of increasing rural health care access, something we all certainly would support. But the proposed method of meeting that goal is flawed. Breaking up the care team will not increase access to care in rural areas. With the flexibility built into Georgia's existing laws, nurse practitioners can already practice in rural areas. Georgia does not require nurse practitioners and collaborating physicians to practice in the same location. That means that today, right now, nurse practitioners have the ability to practice in rural areas if they choose to do so. They just don't. That may be because it's difficult for any medical practitioner to create a thriving practice in rural areas where much of the population may be uninsured or underinsured. The need for care in rural areas has long been an argument the nurses have made to gain independent practice in other states. However, in those states where they do have independent practice, the nurse practitioners do not serve rural areas in any greater numbers than the physicians do. In fact, Arizona has had nurse practitioner independence since 2001. After nearly 17 years, fewer than 11% of Arizona's nurse practitioners are in rural areas, and they serve fewer than 15% of Arizona's rural population. I'm concerned about a two-tiered health system, one in which urban residents and rural residents have completely different levels of care. I do want to point out the comment about online medical schools. There is one. It's called Oceana University. It is online for the first 2 years, then it becomes hands-on and followed by a residency just as every other medical school. There are no other 100% online medical programs, and in fact, zero fully 100% online medical schools. Nurse practitioner education has changed dramatically since its inception. Today, there are NP programs that are 100% online with nearly 100% acceptance rates, many of which require no prior RN experience at all, not 1 minute. And they require as little as 500 clinical hours of experience for graduation. Those, by the way, are shadowing hours. They're not actual hours of patient assessment, diagnosis, and management. In many cases, the students are left to call and email random physicians or other nurse practitioners to arrange their own clinical shadowing experience. There is no formal process for most schools, and there are no clinical standards for the shadowing. The difference in training is night and day. As little as 500 clinical shadowing hours to become an NP versus around 16,000 to 20,000 hours hands-on for family medicine physicians, longer for specialists. That difference is evident when we see recently published studies from Mayo Clinic demonstrating poorer quality referrals and more incomplete initial workups from nurse practitioners than from primary care physicians. Or the study published in JAMA showing that nurse practitioners order more imaging studies than primary care physicians. Or the study published in Infectious Diseases showing that nurse practitioners prescribe more antibiotics than primary care physicians. I can provide many other citations. The ones I've just noted are in the handout that I provided. I'll gladly follow up with anyone who would like them for reference. I have a couple more minutes. I do want to, I haven't had opportunity yet to see the amended bill, but I heard reference to 12 months of experience prior to being able to practice independently. And I would like to comment on that a little bit because medical education changed dramatically over a century ago when the Flexner report came out and showed us that for-profit schools, which included only preceptorships for additional training, were grossly inadequate to provide quality care. And that's where residencies came from. And now we're talking about potentially going back to pre-Flexner days for nurse practitioners to practice in rural areas, and that's a big step backwards. The nurses like to claim they provide a less expensive alternative to health care. I'm not sure how that's true if they're ordering more tests, making more unnecessary referrals, and ordering more medications than primary care physicians. In addition, the American Association of Nurse Practitioners has a stated goal of pay parity with physicians. In Oregon, they've already achieved that, so there literally is no cost savings with nurse practitioners. We've talked about the opioid crisis. I don't need to beat that horse, but I will point out that in Connecticut, where nurse practitioners have independent practice, a nurse practitioner was the single greatest prescriber of opiates in 2015. In New Hampshire, where nurse practitioners have independent practice, nurse practitioners prescribe more opiates than primary care physicians do. There is a better way. Let's increase funding for physician residencies in medically underserved areas. We know that physicians tend to stay where they train. Let's increase loan repayment incentives for all physicians who serve in rural areas. Let's increase Medicaid payments in rural areas to Medicare rates. Let's provide incentives for physicians in private practice in underserved areas in the form of tax incentives. And let's increase telemedicine incentives and availability. Let's keep the team in healthcare. Please vote no on Senate Bill 351. Thank you.
Okay, what's your title? You got Medical Association. Are you the
Pardon?
president? Are you
My
the
title,
president?
I'm a member of the Medical Association of Georgia.
Okay. I just want to make sure I got you right. Okay, thank you. We're going to have to limit our time because there's 2 pages of people who want to talk. So we're going to have just a couple of minutes. Dr. Tanda Lane. Then after that is Suzanne Stapler and Michelle Nelson. Wait a minute, no, I'm sorry, we've got some more opposition. After that's Rick Ward and Jet Tony.
Thank you for allowing me the opportunity to speak today. I will be brief. I just found out very recently that this was going on, so I have nothing really pre-prepared. I am a board-certified dermatologist, a fellow of the American Academy of Dermatology, as well as a double-boarded in the American Board of Medicine and Surgery. I am a clinical assistant professor at Emory, and when I trained at Emory and am from Atlanta and sort of came out of the ivory tower of academics with a very favorable view of nurse practitioners. My mother is a nurse, my grandmother is a nurse, my mother-in-law is a nurse, my sister-in-law is a nurse. I come from a family of nurses and have great respect for them. In the academic community, I think they hold a very valuable place alongside physicians. My husband is also faculty at the Medical College of Georgia and Mercer University, which has a little more outreach in terms of going to rural areas. He felt called to do so. So he did his fellowship in Mohs micrographic surgery, and we decided to go to an underserved area. We've moved about 2 hours south, just outside of Columbus, Georgia. He is the only board-certified, fellowship-trained Mohs surgeon within a 90-mile region. We get referrals from very underserved regions. We have medical students, fellows, and residents come and train with us from Mercer, the Medical College of Georgia, and Emory. And I noticed probably 3 to 4 years ago, I started seeing a massive number of increased referrals that I would classify as inappropriate and even oftentimes grossly mismanaged, if not just frankly malpractice. So I started looking at where these referrals are coming from because Senator Unterman referenced the fact of the dollar sign, and we're all protecting the dollar sign. I likely make more money now from the number of referrals that I get from mid-level providers, so that's certainly not my issue. My issue is when I see patients that have been seen for 10, 12, 14 months. They don't understand that they haven't been seeing a physician because we don't have good truth in advertising laws here in Georgia. And so I wanted to sit down, and my husband and I sat down and looked at what are the differences because I really didn't know. I had great, like I said, respect for nursing. So we pulled our curriculums, and it's interesting today, we were, talking to some of the nurse practitioners. People just really, truly don't understand the training disparity. So in addition, no physician counts college. We all have a college degree. We understand that. After college, after your bachelor's in nursing or biology or whatever, you go on in medical school for a full 2 years of basic science training, gross anatomy, cardiopulmonary systems, GI, renal, endocrine, etc., a full 2 years. When you look at the nurse practitioner curriculum, because I did so, I pulled the Johns Hopkins Doctor of Nursing Practice curriculum. And if you really look at the courses of study, context of healthcare for advanced nursing health policy, philosophical theory of nursing practitioner, health economics, finance, and advocacy. These are not things that we study in medical school. This is why we're not good at lobbying for protection of patients, because this is not a good, we don't get degrees in administration and lobbying. We get degrees in treating patients. After those 2 years, the nurse practitioners are done to practice in whatever field they choose to train in. I have been asked to precept and have done so on 3 occasions, mid-level providers. It was 600 supervised clinical hours, which simply meant they followed along behind me and watched what I did. That's 3 months of a 40-hour work week, and they're released to be a full authorized practitioner of care. For me, I had to go on and do another full 2 years of family medicine, emergency medicine, dermatology, psychiatry, internal medicine. I logged personally 5,000 hours hands-on patient-centered care. Graduate, MD, free to do nothing. Go on and do a full year. I did mine in general surgery. I logged 4,000 supervised clinical hours, graduate, free to do nothing. Went to dermatology residency at Emory, logged personally 6,000 supervised clinical hours, graduate, pass my American board exam. Now I'm considered a dermatologist. The disparity is huge. Myself personally have logged in 17,000 clinical hours as opposed to 3 months of shadowing another practitioner. Georgia deserves better than that.
If y'all could limit your comments to something different than what was previously said, that goes for the other side too, because our time is limited. Rick Ward, then Jet Tony. If you want to come on up.
Thank you, Madam
Jet.
Chair. My name is Rick Ward. I'm sorry, and ladies and gentlemen of the committee. My name is Rick Ward. I'm the Executive Director of the Georgia chapter of the American Academy of Pediatrics. We represent over 2,000 pediatricians, both general pediatricians and pediatric medical and subspecialists throughout the state. Observing your comments, Madam Chair, we just find ourselves in alignment with the other medical groups that have spoken before us, in particular our colleagues in primary care, the family physicians, certainly the Medical Association of Georgia. We have similar concerns. One thing I might add from the pediatric point of view, my members have talked to me about the number of children in rural areas that have complex medical conditions. They might have come by these because of inattention over the years or a variety of factors, and they're particularly concerned about having someone less trained to manage these children without the benefit of linkages and connection and supervision to other physicians. Thank you, ma'am.
Thank you very much. Jet Tony?
Madam Chair, members of the committee, Jet Tony, on behalf of the Georgia Society of Anesthesiologists. Madam Chair, you paid me a high compliment the other day. I wanted to say thank you. You said that I had worked with you in the committee over many years, and I do appreciate that.
Thank you.
And I intend to do so ongoing. Georgia is an anesthesia-rich state. That's not something you're going to hear probably from very many people. And I'm not talking about the brunch bill there. Since 1842, when Crawford Long used inhaled sulfuric ether to anesthetize his patient, Mr. James Venable, to remove a neck cyst, this state has enjoyed an adequacy of anesthesia providers. And just to share in the praise here, Georgia is blessed with 2 excellent nurse anesthetist training programs. Georgia has 2 nationally regarded anesthesiologist assistant training programs. And there are 2 physician anesthesiologist residency training programs. There are 1,000+ physician anesthesiologists licensed to practice in the state. There are 900 anesthesiologist assistants licensed, and there are 1,800 CRNAs licensed to practice in the state. So the coverage for anesthesia and perioperative care is quite good in this state. And I kid you not, we are blessed, because there are many states where there is an inadequacy of anesthesia providers. Now, I bring this up to certainly recognize all of the anesthesia providers, but to make a distinction that is important as this legislation is considered. There is no application for the independent practice of nurse anesthetists who are in the APRN group in the state of Georgia. There is no need to grant independent practice to nurse anesthetists in this state. The anesthesia is not an independent practice of health care. It is always going to accompany and support a procedure or a surgery. And so there will always be a physician present at those procedures. The only caveat to that might be in pain management. And this very committee, Senator Kirk's bill last year, in compromise with the House, created a statement on how pain management will be delivered and how the physician will be involved in that in those instances when a nurse anesthetist is providing the pain care. So respectfully, I would say that nurse anesthetists patients will not benefit from the independent practice of nurse anesthetists. And I will say that I enjoy a good relationship, I think, with the Georgia Association of Nurse Anesthetists and the Georgia Academy of Anesthesiologist Assistants. And I think we all work together to provide the health care that patients deserve. I will say, Madam Chair, that I learned something quite a few years ago when I was somewhat on the other side of a scope issue from the providers. This was many years ago, and a fellow by the name of Bill Lee, who only you and maybe one other member, Senator Henson, Leader Henson, would know, and Senator Jackson in the House, yes. He said something to me to push back on what I was trying to do to expand the scope of of a particular provider group. He said, "Son, we have worked a long time." Remember, he was here 43 years. He said, "We have worked a long time over many decades." Senator Ora, I should recognize you in that regard. Worked many years to create a healthcare system that puts the most highly trained individuals in as many places as we can, and as are economically viable, and we should not pull back from that. So thank you, Madam Chair,
Thank you. I
and members
appreciate
of the committee.
Thank you. Yes.
My question, in fact, I talked to someone, we'll say on the other side, for lack of a better description. I said, you know, you've got APRNs, but then we've got these 4 different groups.
Right, and they're going to come up and
No, but
explain
here's my
that.
question, though, and he just raised the point that I'm trying to figure out. If we've got nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and certified nurse midwives, and we're talking about expanding the scope of practice, what I don't quite understand, based upon what he just testified to, should we do this in all areas for all people, or should it be by category? Because
Well,
what
it-
he said, what Jed is saying, that their particular area, his specialty, if you will, is that they don't feel that it would be applicable to them, and maybe it is applicable to other. Do we need to differentiate between these 4 categories?
Well,
about
there's
expanding practice?
different types of anesthesiologists, nurse anesthetists, and then what is the other group called?
Anesthesiologist assistants.
Assistants, and
then
that's
the
what Senator
physician.
Huffstetler is.
Yeah, 'cause
So
I-
there's 3 different types of people that deliver anesthesia.
No, I understand, but what I'm saying is the way that, and again, I'm using your cheat sheet that you gave me this morning. They talk that there's 4 different kind of, after you get
Right.
past the
You could eliminate one of them if you wanted to.
well, I'm not smart enough
Yeah.
to know that. What
Yeah.
my question is, should we be differentiating between these 4 categories versus carte blanche? I
Well,
don't have
you
the answer.
you could, but that's like saying, you know, we're not going to take the cardiologist, but we'll take the
I don't have
gastroenterologist.
the answer, I just
Yeah.
raised the point.
Yeah, you could.
Okay.
You possibly could. Thank you, Chet. We appreciate
Madam
it very
Chair,
much.
may I respond to a question that Senator Miller asked earlier? In anesthesia care, who holds the liability is going to be different across the state. So there is not a single answer on that. In some cases, it will be the anesthesia practice. In
Well,
cases,
it's my understanding that whoever's in the operating room, when the lawsuit gets filed, that's the ones that get sued.
well, everybody gets sued.
Right.
But,
Right.
but it's, just want to make sure you
Yeah.
understand it's different in each setting.
Yeah, and you know, anesthesia has changed dramatically over the years. Used to, every hospital had their own individual practice. Now it's big corporations that own, and it's like the emergency rooms. Okay, with that, we're going to switch over to Suzanne Stapler and Michelle Nelson. And again, if when you come up, don't repeat anything old, just new information.
That kind of negates all of my pre-formed testimony. So thank you very much, Senator Underman and members of the committee. I'm not going to restate the health statistics that were already stated, but I would like. Wow, you can't hear me? That's a first. But I would like to maybe offer some insight into some of the other arguments that have been made by our colleagues in medicine. The first is that nursing is not medicine and medicine is not nursing. And so as an advanced practice nurse, I don't practice medicine, I practice nursing at an expert level. And while some of what I do crosses over and may be similar to what my physician colleagues do, it comes from a very theoretical and different research basis. In regards to the information presented about radiologic testing and nurse practitioners ordering more, if you lump all nurse practitioners together, that would probably be true because so many of us work in acute care settings. I'm a neonatal nurse practitioner. I work at Grady Hospital, and I'm also faculty at Emory. And so when I am working, I probably easily order 6 or 7 x-rays a day because my patients require that. They're intubated, they're critically ill. So if you lump all of us together and compare us to family physicians on an outpatient basis, that data would look skewed for sure. I'd also like to address the statement about continuing education and maintenance of certification. So in all states but 4, nurse practitioners are required to have board certification and maintain certification in an ongoing perspective. And each certification board has different requirements. The cycle may be 3 years or 5 years, but there are continuing education requirements, there are practice requirements, and there are, for women's health and neonatal nurse practitioners, we have to retake an exam every 3 years to maintain that board certification. So there was inaccuracy in those statements. Let's see. Also, when you look at distribution of nurse practitioners and APRNs in states that have full practice authority, the majority of which are west of the Mississippi, they're actually, when you look at demographics, APRNs are 2 times more likely to be in rural settings versus and underserved areas of urban settings versus our physician colleagues. And that's really focusing in the primary care sector, not nurse practitioners who specialize the way I do in neonatology. So I would just like to offer those comments and clarification points in response to the testimony already issued. Dr. Nelson.
Well, good afternoon, everyone. My name is Michelle Nelson, and I am the proud president of United Advanced Practice, Registered Nurses of Georgia. My statewide organization represents nurse practitioners, clinical nurse specialists, nurse midwives, and nurse anesthetists. I heard a lot, and I think I had something else prepared to speak with you today about, but as I listened to the comments today, I just wanted to make note of my research students that are here with me. I teach research across all levels at Georgia State University. And the one thing I always stress to my students is evidence-based practice. So I did hear a lot of comments today about, isolated stories or studies that talk about not being prepared or advanced practice nurses not being able to give quality care. But there is a significant amount of studies, of research, evidence base that shows that advanced practice nurses across the board are delivering safe and quality care. There are 22 plus states in our wonderful, great country that have had expansion to full practice authority. And in those states, there is a significant amount of evidence that shows that advanced practice nurses deliver quality, safe care. In 22 plus 23, and counting. I think this is more personal for me. Instead of speaking about what works, what doesn't work, I'm not here to talk about nurses and doctors, who's better, who's not better. I'm here to talk on behalf of the great citizens of our state that deserve health care. Isn't that what we're all here for? There are people who need health care. And if it is one more advanced practice nurse that can go into a rural area and stop a life from being stuffed out, stop a woman from bleeding out after delivering, stop a woman from having to drive 80 to 100 miles to get women's health care, is that not worth it? To say that advanced practice nurses will not alleviate the suffering that's happening in the rural areas is even shameful enough to say. That one person could be your mother, grandmother, a child, anyone who deserves but is not receiving care at this time. So what do we do as citizens that have an opportunity to provide those who are suffering the most in our state? There is a workforce of advanced practice nurses who are ready, willing, trained, certified, experienced, and educated to start today. Do we say that we don't give physicians what they need, which is more education, which is more dollars to be able to expand telehealth? I'm all for that. And I'm sure everyone in this room would be. But it is not a reason to deny people care when you have a workforce that is willing and able and ready to give it. So why not? Let's work together. There is no reason why physicians are not doing their work, but advanced practice nurses are not working alongside. There is a significant amount of research that shows that advanced practice nurses are able to handle at least 80% of cases that walk through the door in any primary care setting. So if that is the case, and we can provide that in a rural area, why not? Why not? There are 10 million citizens in our state, 10 million. There are about, 25,000 doctors? Even if you got rid of all of us, you would not be able to see all of the patients who deserve care in this state. There are 13,000 approximately advanced practice nurses. If we combine together and we were able to give the care that the citizens needed, wouldn't we all be better for it? What are we really doing today? I'm not really quite sure. People need care. People are suffering. Advanced practice nurses can be a solution alongside doctors. I happen to practice in another state, in a clinic run by advanced practice nurses, and I can tell you, when we are compared to a lot of other practices that are run by physicians or anybody else, my specialty is anticoagulation. We have won multiple awards for being centers of excellence, for having the highest rates of time within range when it comes to anticoagulation. We can do it, and I know that it can be done here, and the people here deserve it. To reduce it to dollars and cents and saying one group is not going to make money and another group, the community, I'm sure, wouldn't want to hear this. If we went outside and we took this out to the community, what would they say? The people who need care. And so therefore, I implore you today, let's work together. Advanced practice nurses are willing and able. Thank you.
Thank you very much. Right next on the list is a group of rural providers, Janie McGinn, Austin Five Ash, and Bruce Bailey, I think it is. You want to come up? We got quite a few left. There. Yeah, I know. We have a 3 o'clock. And I inadvertently, someone wrote on the top of this page, the Georgia Radiological Society. I didn't know they were up there. So let's get these people that drove so far. We've got another group of rural providers. Let's get them, Kate Dirks and Lynn Brown, if y'all go ahead and come on up. These people drove a long ways from South Georgia, I think. At least it says on here they did. Thank you.
Thank you, Madam Chair. Thank you, members of the committee. I'm Janie McGinn, and I'm a nurse practitioner and retired educator. And I'm from Valdosta, Georgia, and I am here to support Senate Bill 351, and also to speak to 256,000 people with diabetes in the surrounding counties, and that is 8 counties. The counties are Berrien, Brooks, Cook, Eccles, Lanier, Lowndes, Hamilton, and Madison. There's only one endocrinologist around, and there's 2-year waiting list. I see and manage people with diabetes, and some insurers will not credential me because I'm a nurse practitioner. And my collaborating physician is 80 years old, and I know that he will be retiring soon. And I'm afraid that if that happens, I will not have a collaborating physician. I have been in practice for about 3 years. My practice has grown. As you know,
How many people are in your practice?
you mean how many
Population?
population?
How many patients do you take care of in your practice?
A lot. and my patients are doing very, very well. They love me. I can't see that many because I love to spend time with my patients, and that is the reason I went in and started my business. Because I was working for a family practice physician, and I didn't have the time to spend with them, educate them on how to use their diabetes monitor, how to monitor their diabetes, how to talk to them about what to eat, and I was not doing justice for them. And being an educator, I felt that that's what they needed. And so I beg you, these people with diabetes already have enough to worry about. They do without food to buy their insulin, and they have enough to worry about without not having a provider. Some of them have to drive and take their children over here to Macon because there's a 2-year waiting list to be seen by the endocrinologist. So please help us. Thank you. Mr. Five Ash had an accident turn into the exit or getting off the exit, and he couldn't be here. Yes. Valdosta. What he wanted to tell you all was that he had a patient that I taught Austin, so I know a little bit about his situation. He had a patient who his son lives in Tifton, and the patient lived in Valdosta. His appointments with his primary care provider were canceled twice. The son had to take off from work to take him, and then the father or the patient got diagnosed with cancer, and he got very depressed, and he thought, well, he's going to have to, continue to do this, and he said he couldn't take it anymore. So he shot himself because he just couldn't put his family through that, and if he had to go and not be seen, and so that was the case, and it just broke his heart. So we really need more primary care providers, and I think having nurse practitioners take some of the load would help.
Thank you. Please give him our regards, and we appreciate him driving up from Valdosta, and he's probably not used to Atlanta traffic. So welcome to Atlanta, right? Bruce Bailey.
Yes, ma'am. Good afternoon. Thank you, Senator Underman, for inviting me to come today.
And where are you from?
Distinguished panels. I'm from Wilkes County, Washington, Georgia.
Okay.
My name is Bruce Bailey. I'm a board-certified nurse practitioner in a small rural resident practice in Wilkes County. I've been in the healthcare profession since about 1991 when I got out of the military. I became an EMT, paramedic, LPN, RN, and now I'm a nurse practitioner. And I continue to maintain my license as a paramedic and work effectively with the local services. When I began working in Wilkes County in 1992, there were 8 physicians and 2 physician assistants. Today, we have 3 physicians in Wilkes County, and one of them that's admitted into the hospital, and one of them is actually in a neighboring county and is the only family certified physician. The other 2 are internal medicine, and one's a pediatric doctor. They admit to the hospital. We have a critical access hospital that is about to close. They have enough money to last about 3 more months.
What hospital is that?
Wills Memorial Hospital in Washington, Georgia. As you all know, many factors come into play for the rural hospitals in Georgia, and with the passage of Senate Bill 351 allowing nurse practitioners greater allowances and greater access to providing better care, we'll have the means to maybe keep that hospital open. I already have two other nurse practitioners that want to come and work with a practice that I only opened 4 weeks ago, and I'm already averaging 20 to 25 patients a day because they can't get into the other physicians' offices. And if they do, they have to sit and wait for hours and hours and then get turned away at the end of the day. The city of Washington is located in between the larger cities of Athens and Augusta, an hour each way. So we're kind of in the middle. But we also serve Taliaferro County, which is the poorest county in Georgia, with 10,000. My county alone has 11,500, way under the 50,000 that's currently there. Without the use of nurse practitioners, rural hospitals will close. They will shut down. I can't admit to the hospital. But with this passage of this bill, I would be able to admit to the hospital. I would be able to follow my patients through the beginning of care to the time they're discharged. As a nurse, I spend more patient time educating my patients on the quality of life and the care that's needed for them than physicians do. I just have three statements that, as RPNs, or advanced practice nurses, we did not cause the opioid problem, but we are ready to help fix it. And we can, if given this opportunity. We also want to invite the physicians in this room. Me personally, I could have stayed in Augusta or in Athens and made lots of money, but I want you to come to Wilkes County, Tolliver, or Lincoln and work with me. See what we see. And then also, the physicians that allow the students to just follow did those students an injustice. Those students should have been working, doing what we're trained to do as nurses: assess patients, manage their care, and educate those patients. For any physician that allowed a patient or a student to come and just follow you, that's an injustice. That's wrong. So please, I'm the firm believer: see one, do one, teach one. I'm a preceptor for nurse practitioners. They do the work. I back them up. Thank you.
Make sure the people that drove along.
I did. I came from Thomaston, Georgia, in Upson County.
Good.
About 2 hours down south. And I'm
Good.
actually really honored to speak to you, Madam Chairman, and
What's
to
your
all
name?
of the senators. My name is Catherine Dirks, and I'm an Emory midwifery student who's lucky enough to do her training in Thomaston, Georgia. And what I just really want to make a sort of a brief point representing maybe the future of advanced practice nurses who are coming down the pike and who are training here in Georgia. I can tell you from personal experience that my colleagues are talking to me every day about leaving this state and going elsewhere to train, to continue their practice because of the restrictive policies that are here in Georgia. We are behind the rest of the country, and my colleagues are anxious to use their full training and their full education. That is very high quality, and I'm very proud of my training as a midwife at Emory. And I just want you to know that these have real economic impacts. I mean, these are job creators who would be leaving the state of Georgia to practice elsewhere. These are graduate schools that have gotten something like $40 million in tax money from the Board of Regents to invest in educating Georgians here in the state, and we want those folks like me to stay here. So other folks who've spoken today are right. We typically do stay in the places where we train. I love Thomaston, Georgia, and the women who are there, who, by the way, are dying in childbirth. Our state is 48th in maternal mortality. That's the most recent number. They are really asking for midwives, and midwives have great outcomes, and we can make a difference in those areas, but not if students aren't able to stay here and work. And what will really attract good workforce, keep students here that we're training, and in fact, attract them from other places is great policy. And I think that that's what we have here with SB351. So I encourage you very strongly to vote yes on this bill and keep the bright and best students here in Georgia to work for our citizens.
Good morning. My name is Lynn Brown. I'm an advanced practice registered nurse. I've been a registered nurse for over 20 years in the state of Georgia. I've been an APRN for a couple of years now.
And where are you from?
I am from Eastman, Georgia. I am
Eastman?
in the rural. I am in the heart of rural Georgia. Okay. I'm an hour
writing that
from.
down as we
I'm an
speak.
hour from Macon. I'm 30 minutes from Dublin. But I want to tell you why I opened my practice. Okay.
Do you want to talk a little bit louder? You're on video.
Okay. I want to tell you why I opened my practice. Patients are having to wait 3 months to get in primary care. in my community. That's whether it's advanced practice nurse, a physician, or a PA. Patients are having to wait, and then whenever they're actually getting in for sick, they're waiting 3, 4, 5 hours at a time. I open my practice to serve my community. That's what we're here to do right here today. We're here to let our community as a group know that we are needed and that we are. Nobody's trying to say that we're not physicians. I never tell my patients I'm a physician. I always correct them when they call me doctor. I am not a doctor. I do not hold a doctorate title. I may or may not decide to go to doctorate school. That's neither here nor there. The point I'm trying to say is that we're all a team. We all need to work together. We also need to understand that none of us can provide the care that we're doing right now. The numbers are not there. We need more providers. How we get that is by expanding our scope. Right now, basically, I have a collaborating physician. He is a very good physician. He's known me since I was a young child. But you know what? He's getting ready to retire. As most of the physician force is aging, the nursing force is as well. So, you know, that if he was to retire next week, he has 4 APRNs under his belt right now. So that being said, I have 750 in my practice, and I've been open for less than a year. I see 20. I've been open less than a year.
And you have how many patients?
750. And I'm opening a second clinic on Saturdays starting this Saturday.
You what?
I'm opening a second clinic in another location on
Where is
Saturdays. It's going to be in Ryan, Georgia, which is about 15 miles from Eastman. Dodge, Telfair line. And again, it's Senator Kirk's domain. He's aware. Yes, I think that's right, the Duke's house. But anyway, long story short, I have over 20 years of nursing experience. I've followed physicians' orders for years and years and years. I believe I can assess a patient and I can make rational decisions. I am board certified, and I will continue to be, and I will continue to meet the needs of my patients by taking care of them and answering their questions and taking the time to let them know that I am there for them, whether we're a physician or doctors. It doesn't matter.
And Senator Calsert, when you refer a physician from Eastman or when your new clinic's open in Lyons, and we've all been to Lyons because of Tommy Williams, us old-timers have.
Right.
When you refer a patient, where, like they go to a cardiologist, where's the cardiologist?
Well, we actually have, most of our cardiologist offices are in Macon. There's one group in Dublin, maybe 2 groups in Dublin. So either way, you're talking 30 minutes to an hour or more driving time. We do have one cardiac group that does come to Eastman 1 day a week, and it's generally staffed by a nurse practitioner with a cardiologist there maybe once a month. So the providers are still being, or the patients are still being seen by advanced practice registered nurses.
Okay, Senator Calsert.
Thank you, Madam Chair. Well, so it sounds like to me in your part of rural Georgia, the current system is working. You have a collaborative agreement with the doctor. If one of your 750 patients needs a prescription or an X-ray or CAT scan, how does that happen?
Well, sir, yes, it does to a certain extent work. There are times whenever I have to call my physician, and if he's busy in the emergency room because he does internal emergency medicine as well as his own clinic, then I have to, speak, get him on the phone and get the order to order if I have a question, or if I have to refer out. I can call, and there are times I send my patients to the emergency room if I can't, take care of their needs there and get the doctor to follow. But that's being said, that's with any profession, whether it's a physician or a nurse practitioner, we all should collaborate together. So, but what I'm trying to say is, if my physician was to quit having us right now, and we had to, I'd be closing shop. I have 5 employees. Not only that, but my community would, there would be 4 less providers in that little radius of the area that he covers for us. So you're talking at least probably a group of, if they all had the same amount of patients, that'd be at least 3,000 or 4,000 patients that would no longer have a provider and would have to drive even further.
And I think, again, the connection.
No, wait, you can't talk. I'm sorry, she's got the microphone. And Senator Calsert, do you have another question?
No, that's all I had.
Let's see. Did you have anything else you wanted to add before you drive back?
No, thank you for having me today. I appreciate everybody taking the time to listen to us. And
I think we have to move on. We only have 6 minutes left. And obviously, we're not going to get through this list. Obviously, we're not going to vote today. I do want to take this into consideration. I've had several suggestions. I think it would be in the best interest, some of the input I've heard from some of the members, to work on another committee substitute. If you have suggestions, I know you had the suggestion about the opioids. I've gotten some text messages, what about this, what about that? I would suggest to the members of the committee if you would put those in writing and give those to me, and I'll work on another committee substitute, and I'll work with you. And I know time is very difficult between tomorrow's a busy day on the floor. Is there anyone else who drove a long distance that cannot come back on Thursday? Is there anyone here that cannot come back on Thursday that signed up? You can't come back? Okay, you want to come up and express what you have to say. The Regulated Industries is knocking on the door. And Dean Marion, if you want to tell us about Augusta.
Okay, thank you. I'm really here to talk about education so that we can clarify that as much as I can. I've been very...
Can you talk louder, please?
I've been very active in education of APRN since over 40 years. I helped create the first graduate program in South Carolina, and I've been in Georgia 14 years working on this same issue. And I'm also from Telfair County, raised in Scotland, Georgia, so some of you have already heard me talk about that. So I do know about rural health care, and I greatly appreciated the comments, the previous comments. But Senator Underman and all the senators, thank you for letting me be here to talk about this. We did present a lot of this information in SR 188 study committee, and we appreciate that opportunity too. But I'm just going to summarize the education of APRNs in the state of Georgia. I'm not going to try to cover the national front, but we do teach all of our students at the national level. I will tell you that. We do not teach regional, we do not teach state. We do teach about our population more, but we do teach the knowledge and competencies. So every APRN in the state of Georgia has had basic nursing education. So a lot of times nobody gives us credit for those hours of education in pharmacology and pathophysiology and nursing and health promotion and all those things. So they've already had basic nursing, and then they enter at least a master's degree, with more and more getting practice doctorates and research doctorates. And we'll talk about the practice doctorate in a minute. But they have attended a nationally accredited program which meets national educational standards, not just state-of-the-art, but standards. And this includes accreditors visiting our sites, going to our clinical facilities, and so on. So the average number of hours, and we've already heard there is a range of hours. The more specialized you are, the neonatal intensive care nurses, the nurse practitioners, the nurse midwives, nurse anesthetists, versus the ones who are more in primary care. Although, as they have a broader scope in primary care, such as babies to elders, they have more hours. So it ranges a lot. But overall, if you look at the specialties and degrees, you would think 800 hours plus rather than minus. In addition to the BSN, and in addition to the fact that most do practice all the way through their program. Even if they move straight from the BSN to the APRN, they're practicing as a nurse. That's why they do so well in our programs. They're very current, and they know what's going on in more than their education. So in our programs, we also, the faculty, it's mandated by our accreditors, and good sense, but by our accreditors, that we require and monitor progressively complex care of patients under faculty and preceptor supervision. And we've already discussed that, so I won't go any further, but we do expect every student to progress. We're monitoring how many pap smears they've done. We are monitoring this kind of activity. And if that clinical practice does not allow the student to learn, then we take them out as quickly as we realize that. We do offer online education, and I know that's an issue for many people. We find that online education is superior to standing in front of a group and lecturing, because with online education, we can teach state-of-the-art at any moment. The student is an active learner. They're looking it up. We're not spoon-feeding them, and we find this is superior. I've been teaching through distance methodology. I taught on ETV. That's how we managed it in South Carolina in 1984. So in nurses, we have been reaching out to those rural nurses so they can be educated through their computers. And the nurses working in underserved areas, and they can't get to the classroom through the Atlanta traffic. And then they can't, and for whatever reason, they find it easier. And they're working, as I've already said. They're current. They know what's going on. So all of this works for nursing because of our great philosophy of serving all of our nurses wherever they might be. We are also able to monitor them more closely because we can watch them on the computer as they get knowledge acquisition. So I would love to talk more about this. We don't have time. So the last thing that every single APRN in this state has accomplished is they are nationally certified, and they vary widely based on their particular specialty, but these are national exams. They are normed. They are pushing the envelope at all times. We're raising the bar on our education every single year. And I just want to go back to that DNP that we heard before. There are post-master's DNPs out there. We started out that way. Everybody was a nurse practitioner or a nurse midwife, and they had a master's degree. And when we raised the bar on our vision of what APRNs would need to the doctoral level, most of those people coming for the DNP were already certified clinicians experienced. So therefore, their education was focused on public health, health policy, evidence-based practice, so they could change practice and make it better wherever they were. Thank you, Madam Chairman.
Mary, answer a question for me.
Okay.
In other states, do they subtract the different subspecialties of APRNs for, like Senator Miller was talking about, for nurse anesthetists? Do other states have a scope of practice where they delineate some of them out of it? Do you know?
Yes, there are some.
There are some that do
and
that?
sometimes and I'm not going to speak for the nurse anesthetists because I'm not prepared, but
Right.
sometimes they have reasons that they actually don't find it compatible with their practice to be part of the APRN.
Are
Other
there
times
any
it is.
others, like midwives or any other?
Sometimes the law has done that. The nurse midwives, as far as I know, have not asked for that. But again, I'd have to defer to them.
Yeah.
But sometimes it's a little.
I'm
For-
coming.
And if I could defer to
No, that's
those
okay.
speakers.
We'll do the
And I'll get this
research
in
on
writing
it.
to answer you
We
that.
will do the research on it because I know some of the committee members had questions about that. We'll do the research and we'll have that on Thursday.
I
Dean Merriam,
apologize.
we appreciate what you do at Augusta
Thank you.
University. Before you get up, wait just a minute. I want to see how many students are here. Is there students here? Do you want to stand up? I want to give you a round of applause. We appreciate what you do and what you're learning, and do hope that you will stay and you understand with workforce development how valuable you are and how much we want you to stay in the state of Georgia. With the committee, if you can submit your recommendations to me on any changes to the bill, hopefully you're going to vote for the bill. If you're opposed to the bill, please tell me what your opposition is. And so that when we're working on these compromises, perhaps we can work it in. So with that, on Thursday is going to be Nurse Day because we're going to do the other nursing bill, and we will be voting on this bill on Thursday. Thank you very much. I appreciate y'all coming.